Hey guys, next, Judy Baumhauer from Rochester will be moderating the session. Judy's always got fantastic insight and always pulls great faculty for us. So Judy, looking forward to the session.
Hey, thanks a lot, Selene. We're super excited to be invited here at the University of Rochester. And I have with me three of my partners. And we're going to tell you our topic is entitled Life Beyond the Fusion, Evaluating Postoperative Function and Quality of Life. But we're going to tell you, first of all, how do patients do after ankle fusion? And really out of the horse's mouth, meaning patient-reported outcomes and some outcomes that you might want to take into account when you're giving advice to your patients. So first of all, I'm so delighted that my three partners have come along. The first is who we'll hear from is Amanda Holleran, who will talk about ankle fusion outcomes, past and present, legacy, promise, and beyond. You all know how much I love promise. And then Emilie Williamson will talk about objective function after ankle arthrodesis, gait, range of motion, and long-term expectations. And finally, Dave Ciufo will talk about fusions outside the box and returning to sports and higher function. So thank you all for coming on board and for all your expertise. And we welcome questions, so put them in the chat. We want to hear what you have to say. You're on.
All right. Hi, everybody. Thanks so much for joining us. I'm going to talk about ankle fusion outcomes, past and present. So kind of outcomes from the past, and then where are we at today? I have no disclosures. So just a quick overview of ankle arthritis and fusions. So the etiology of ankle arthritis, post-traumatic, is the #1 cause. There's also other causes like primary osteoarthritis, long-standing instability, rheumatoid arthritis, and things like gout and hemophilia. Ankle fusion was once thought to be the gold standard of treatment for ankle arthritis. However, as total ankle prostheses have evolved and become more reliable, they've become more common. But there's still a role for ankle fusions. The indications for ankle fusion is end-stage arthritis, causing a painful ankle, and this could include infection, Charcot, AVN, or instability. Most commonly, ankle fusions are being done for severe deformity and in the younger patient population. As with anything, there are pros and cons. The pros of the ankle arthrodesis is reliable pain control, and this procedure generally brings a low complication rate. Many studies have shown that ankle fusion provides good short and medium-term results. However, in the long term, it does pose a major risk of the development of adjacent joint arthritis owing to the transfer stresses to motion of other joints. And other complications following ankle fusion could include pain, dysfunction, non-union, malunion. There are multiple techniques available. Arthroscopic technique, which usually has high union rates, but more difficult to correct big deformity. There's mini arthrotomies, which is a good alternative to the scope, but again, difficult to correct large deformities. And then the traditional kind of open approach, which you could do anteriorly or laterally. And this allows for more correction of bigger deformity. And just like any foot and ankle surgery, the principles for an ankle fusion are to respect the soft tissues, meticulous joint surface preparation, rigid fixation, and appropriate position of the ankle. Position of fusion should be in neutral dorsiflexion, valgus, 5 degrees of external rotation, and posterior positioning of the talus and the mortise. Complications can occur with any surgery, and ankle fusions are no different. So non-unions can occur as well as malunions, which can cause other issues with the foot and ankle and ongoing pain and discomfort. So looking at outcomes of the past, there are a ton of studies out there looking at ankle fusions, and it's really challenging to kind of take away points from these studies because there are different techniques used for fusion, whether that be arthroscopic versus open versus mini open. There are different ways and different hardware placement, plates versus screws. It's hard to compare apples to apples, and there are very few validated or reliable outcome measures used. And there's many studies that just report short-term follow-up and complications. Nonetheless, though, we're going to go through a few of them, and there are a ton, like I said, out there. And these are just a few that I looked at. But I'm going to pull just a couple because I think that they're interesting and I want to highlight them. And so the first is this randomized controlled trial out of the UK comparing ankle fusion to total ankles. And so from 2015 to 2019, the study ran. There were 303 participants that were randomized either into the total ankle group or into the ankle fusion group. There were 144 patients in the ankle fusion group. And they looked at the Manchester-Oxford Foot Questionnaire, walking and standing domains specifically. That was their primary outcome. And they found that both total ankles and ankle fusions had improvements in the score, but there was no significant differences between the groups at 52 weeks. When they broke it down a little further in the total ankle group, they did see that fixed bearing total ankle devices did have a significantly difference when compared to ankle arthrodesis. The non-union rate of their ankle arthrodesis was 12%, but they found that only 7.1% were really experiencing symptoms if they did have a non-union. This was a systematic review by Haddad and his group looking at total ankles versus ankle arthrodesis, and really the goal of this study was to determine whether there was significant objective data in the literature to compare the two procedures. Can we really say is one better than the other? So specifically just looking at the ankle arthrodesis, 39 studies evaluated ankle fusions. Their AOFAS ankle hindfoot scale was 75.6 points. 31% had excellent outcomes, 37% had good outcomes, 13% had fair outcomes, and 13% had a poor result. They found that the revision rate following an ankle fusion was 9%, and the main reason for revision was non-union. This is the COFAST study looking at intermediate term results of total ankle replacements and ankle arthrodesis again, just focusing on the ankle fusion portion because I know Dave is going to go, a little bit into more of the comparison here coming up. But they looked at 107 ankle fusions, and the ankle fusion patients tended to be younger. They were diabetic. They were less likely to have inflammatory arthritis, and they were more likely to be smokers. 7% of their ankle fusions underwent revision, and they found comparable outcome scores between the two procedures. So to summarize all of these kind of older studies looking at outcomes in ankle fusion, the studies really uses multiple different techniques. So it's, again, really hard to compare apples to apples. Union rates, though, throughout the literature were 85 to 100%, so pretty reasonable union rates. And patients had good or excellent outcomes and or were satisfied more than 80% of the time. Their AOFAS scores were 68 to 81. Now, it would not be a University of Rochester talk if we didn't talk about PROMIS and patient-reported outcomes. The nice thing about PROMIS is that it focuses on basic functional outcomes such as walking and stair climbing that are specific to foot and ankle function and not necessarily to a patient's general health status or ability level. And the advantage of using PROMIS is that health-related quality of life estimates can be determined from specific PROMIS domains such as physical function and pain interference. The success of foot and ankle surgery patient is really our ultimate goal of care. We all want our patients to be happy after they have surgery, and we all want them to feel like we helped them get better. The nice thing about PROMIS is that it's NIH supported, it has validated questions and domains, and we also use computer adaptive testing, which saves time and redundancy. They're not filling out these huge, long questionnaires that may not pertain to their functional level. So the T-score provides patient data in relation to the population average. 10 points is one standard deviation, and a score of 50 is the population mean. And just looking at the common domains that we use, physical function. And so if you have a higher score in physical function, that's better. Mood and depression, if you have a higher score, that's better. Whereas pain is actually the opposite, where a lower pain score is better. But in our display, we actually use the inverse of pain, so up is good. So I actually am going to use a patient of Dave's who had ankle arthritis. And this is what our outcomes look like for this patient with ankle arthritis. So he presented to the clinic and was diagnosed with ankle arthritis, and appropriately so, Dave treated him with NSAIDs, a brace, some rocker-soled shoes. However, the patient came back and still was having issues. His pain was worse, which I guess, let me pause for a second. I should have told you that the blue line is the depression score. The green line is the pain score, and the red line, the physical function score. And so you can see when the patient returned that his function was actually less than when he previously came to us, and his pain got worse. Had the discussion, man, maybe it's time to do something for him since he's kind of really suffering due to his ankle arthritis. So this is the time point that he underwent an ankle fusion, and his physical function is kind of in the tubes. We keep people non-weight bearing after an ankle fusion, and so that makes sense. However, the pain score improved and now is in the green, and his depression score improved as well. We see this pretty commonly, that many patients are pretty hopeful after they have surgery. This is when that patient got a walking cast, so physical function improving as they're starting to ambulate. This is when they're out of the cast and going to physical therapy. And you can see this is their improved recovery with improved function. And so our pain score improved a great deal, and their function score improved as well, not quite as much as the pain score. And we'll talk about that too. So this was a paper out of the University of Rochester, and the purpose of this study was to determine the temporal change in patient-reported outcome measures using PROMIS, and using these T-scores for patients undergoing ankle fusion for primary ankle arthritis. And the secondary goal of this study was to determine the recovery pattern, so kind of develop a roadmap and say, gosh, what is in the realm of normal? Not that all patients are going to fit in that box, but what is in the realm of normal for our patients, and what can we tell them to expect after surgery? So on the left here, you can see this is physical function, and you can see this is pre-op, and then these are all the time points post-operatively. The little stars here demonstrate a significant difference from pre-op, whereas the hashtag or number signs demonstrate a significant difference from the time period previous to that. So looking at physical function, we can see, yep, that physical function, immediately after surgery, again, does that dip because patients are non-weight bearing, and then starts to climb and kind of improve. And you can see what that looks like. And then their pain scores, again, significant pain, their pain improves after surgery and then kind of levels out. And what you can see in both of these graphs is that about 120 days or so, or around 4 months, they kind of seem to level out in both ways, both for physical function and pain interference. Based on these results, patients appear to gain the most benefit in pain reduction after arthrodesis. So we found that there were greater improvements in pain relief, but function really wasn't improved as much as we would have liked it to. And it was a minimal clinical important difference in pain improvement, but not necessarily function. And so the other thing, though, if you notice on the previous graph, is that the pain wasn't zero. So there was still some discomfort after an ankle fusion. However, patients were much better, significantly so than they were preoperatively. And then the other goal of this paper was to kind of develop this roadmap to determine, gosh, what can we tell patients to expect after an ankle fusion surgery? And it looked like that about at 4 months after surgery, improvements in physical function and pain really plateaued with minimal changes after this time point. So you can kind of tell patients, yep, this is something that you might expect long-term after an ankle fusion. These are just some other studies that really replicated similar results to this. These studies demonstrated that, again, there was significant improvement in pain after ankle arthrodesis. However, function maybe wasn't quite as improved as we would have liked it to. And I know Emilie is going to go through and talk more specifically about function and how these patients do, and as well as Dave. So we'll get a little bit more of that as well up in the talk. So stay tuned for that because it's going to be interesting. So in summary, I still think that there's a role for infusions. I know total ankles are really exciting, and there's a lot of technology and improvements in the implants, and they're becoming more and more common, and more patients are indicated for a total ankle. But I do think that especially in the younger population and our diabetics with neuropathy or previous infections, that there's still a role for an ankle fusion. So it's important to know how to do one and what to tell our patients. There are good early term results with more than 80% of people being satisfied with their outcomes in the literature. And so that's great. You can tell people, 80% chance you're going to be really happy with this procedure early on. We find that pain scores improved, significantly so, but they may not be 100% pain-free, but it should be significantly better than what they started with. However, their function may not change all that much. And again, we're going to look forward to Emilie and Dave getting into function a little bit more and talking to us about that coming up. Outcomes may worsen after time, and this is thought to be due to adjacent segment arthritis. The question is, when does that happen? And then finally, looking at ankle fusion versus a total ankle replacement. Is one truly better than the other? Is one superior? And I know Dave is going to talk to us about that. So exciting talks coming up, and I'm going to turn it over to Emilie now.
And thank you, Amanda, first of all, for talking about promise. Love that. But thank you for not mentioning about the AOFAS score, which is not a validated instrument, and we really have to avoid using that as a patient-reported outcome because it wouldn't be helpful.
All right, so can everybody see that? Looks okay? So hi, everybody. My name is Emilie Williamson. I am the newest partner at the University of Rochester in the Foot and Ankle Division. I will be discussing objective function after ankle arthrodesis, including the range of motion, gait, and what we can expect from our patients longer term. I also have nothing to disclose. So as you already heard, Amanda already gave an excellent introduction to ankle arthritis, so that can allow me to go through these next few slides a little bit more quickly. But briefly, just as a review, if anybody jumped on and didn't hear her first few slides, 80% of ankle arthritis is post-traumatic in nature. Patients generally present with ankle pain, stiffness, swelling, mechanical symptoms, and tenderness to palpation, and often with reduced range of motion, deformity, and ligament instability. And that motion is something that's important to think about as I go through my talk. Importantly, and as she mentioned, these patients tend to be younger than hip or knee arthritis patients, and often with prior incisions and a thin soft tissue envelope. Non-surgical management and arthroplasty were already discussed a little bit earlier in this webinar. And so today, this group is kind of focusing on ankle arthrodesis primarily. There's different approaches, again, that have already been mentioned, and different fixation options. And these are based on the etiology and the amount of deformity, such as, do you preserve the fibula or do you take it down? Are you going to be doing a total ankle arthroplasty in the future, which Dave is going to talk about? Is it arthroscopic or open? Do you make flat cuts or do you try and feather the articular surface to preserve the shape? And again, the optimal position is something that none of us can forget, that it should be a neutral flexion, 5 degrees of hindfoot valgus, and 5 to 10 degrees of external rotation. So one thing to take into account after an ankle arthrodesis, or especially as we're talking to patients before they go through with it, because every single one is going to ask about it, the word fusion, kind of scares people that they're not going to have any motion afterwards. So motion within the lower extremity and the foot and ankle, it's obviously not limited to the ankle alone. And there is compensatory motion through the hindfoot and midfoot, as well as the remainder of the lower extremity, the knee and the hip, that a lot of us foot and ankle surgeons sometimes don't pay attention to. Motion in the hindfoot is directly related to the mid-tarsal stability during gait. So with pronation or eversion, this unlocks the mid-tarsal joints, providing flexibility in the midfoot to tolerate weight transfer from foot strike to flat foot. And then supination or inversion locks the mid-tarsal joints, providing a rigid midfoot to stabilize the foot for toe off. In ankle arthrodesis, these motions in the subtalar joint and the midfoot are not sacrificed, so those are still intact. The subtalar motion after ankle arthrodesis is what allows for motion in gait after this fusion, compensating for the loss of tibiotalar motion. So this prospective radiographic study looked at the sagittal range of motion before and after ankle fusion. They included 48 patients who underwent isolated ankle arthrodesis for post-traumatic arthritis with a minimum of 1 year follow-up. Pre- and post-op standardized dorsiflexion and plantar flexion radiographs were taken, and they found relative hypermobility in the subtalar joint and the medial column joints after ankle fusion. The mean sagittal motion, including tibiotalar, medial column, and subtalar joints, preoperatively was about 40 degrees, of which 17 came from the tibiotalar joint. And this decreased to about 23 degrees post-op, with an increase in subtalar motion by 4 degrees from 5 to about 9. And while that does allow for gait and patients demonstrated better quality of life with increased compensatory motion, this increased motion is also what accounts for increased subtalar joint arthritis in the future from impingement of the posterior part of the posterior facet of the subtalar joint. In this next study, which was actually comparing total ankle replacement and ankle arthrodesis, I'll focus on the arthrodesis side of things. They demonstrated a postoperative arc of motion of 24.3 degrees. So this was similar to that previous study, but they also focused on the talonavicular joint specifically, and found that the talonavicular joint contributed a mean of 22 out of those 24 degrees. So they proposed that this also predisposes ankle arthrodesis patients to degenerative changes in the talonavicular joint over time. And so that's the motion. You do still have some compensatory motion from the subtalar and the midfoot joints, but what about gait? So if there's compensatory motion, does that mean that their gait will be normal after surgery, or at least better than what it was before? And so there's multiple components that are involved in the normal gait cycle, which were described by Saunders et al., including pelvis rotation, pelvis obliquity and tilt, knee flexion in stance phase, foot and ankle motion, lateral pelvis displacement, and the axial rotation of the lower extremities. And if more than 2 of these are compromised, then a patient will have an insufficient gait. So after ankle arthrodesis, obviously the motion of the ankle and the foot is changed, but the loss of ankle motion is compensated for elsewhere. In this prospective 3D gait analysis study in patients with ankle arthritis, they found an improvement in their gait after ankle arthrodesis compared to what they had preoperatively. They found improved speed, step length, and interestingly, range of motion in the ipsilateral hip and knee, as well as the contralateral knee and ankle, demonstrating further compensatory measures from the rest of the body outside of the subtalar joint. With regards to overall sagittal motion, they didn't find a significant change in the range, perhaps because they thought the arthritic ankle is already stiff, and these patients probably already had some element of compensatory subtalar motion or hypermobility. And so while they did find improvements compared to the preoperative arthritic ankle, they still were not similar to the contralateral unaffected ankle. So even though the ankle is better, it's still not normal. In this study, they included 18 patients with end-stage ankle arthritis, 9 who had ankle arthrodesis, and 9 with arthroplasty. And they included pre- and post-op assessment of pain, physical function, and gait analysis. And in the arthrodesis group, they found decreased pain and improved gait function with an increase in velocity and stride length. They also demonstrated increased hip range of motion, as well as the expected decreased ankle range of motion. But interestingly, and going back to the function that Amanda already mentioned, despite these improvements, they did not increase their step count, implying that even with reduced pain, it might not actually change their activity or function level. And in another study, including 12 patients with successful ankle arthrodesis and 12 controls, as well as 12 arthroplasty patients, gait analysis was performed pre- and post-operatively. And once again, they found, though normal walking speed and movement were not restored, they found a faster gait and longer step length after arthrodesis. However, they still had asymmetry in the timing of their gait. And so this slide in this paper was generously provided by Judy, that even though gait improves after arthrodesis from their preoperative gait, is there anything else we can do to improve it even more? And this study looked at gait in 9 patients who underwent an ankle arthrodesis and 9 with normal ankles, and evaluated their gait both barefoot as well as while wearing rocker bottom shoes. So they found that while the shoes did not change the arc of motion for the patients with normal ankles, they increased the total arc of motion by about 5 degrees in the patients with ankle arthrodesis. And so these shoes did not have any effect on gait velocity, and they did not provide enough motion to restore it to a normal arc of motion. But overall, it is another tool that we can use to help provide these improvements in their gait for patients who are going to undergo fusion. And finally, because not all gait is walking on a level surface in a controlled lab setting, even after successful fusion, 79% of patients reported difficulty on uneven ground, 75% reported difficulty with stairs, and 64% reported aching with prolonged activity. And so while these patients do have improvement in their gait after surgery, their longer stride length, they improve their speed, compared to their arthritic ankle, what should we be making these patients aware of, and what should they expect in the future? And so ankle arthrodesis, it does provide satisfactory outcomes in daily activities, But a lot of these patients, and one of the indications that we already kind of talked about, is that they have a more demanding lifestyle, more high impact, younger patients. And so this study included 185 ankles with a mean follow-up of 8 years. And they found after successful fusion, sports participation reduced from 80% preoperatively to about 70% postoperatively. 73% were able to hike post-op, 17 were able to run, and kneeling could be done for an average of 10 minutes in 40% of patients. So overall, most patients remained active in sports, but a transition to a less demanding sport was frequently encountered. In this review of 60 patients who underwent ankle fusion for post-traumatic ankle arthritis, 30 patients at an average of 7.3 years revealed virtually no subtalar motion, but with some preserved motion in the show parts joint. They also found that in those who had varus or valgus angulation of their hindfoot, this was associated with a greater degree of symptoms in the subtalar area as well as in the hindfoot. And with shoes, they had a near normal gait. So once again, this shows that the hypermobility and the compensatory motion that we see early after these fusions is likely predisposing them to degenerative changes in the future. And eventually they have virtually no subtalar motion. In this study of 66 ankles with mean 9-year follow-up, they found that patients are more likely to have progression of their arthritis in adjacent joints if it was present preoperatively. So they found subtalar arthritis in 60 patients pre-op, which is 91% of their patients, and 20 progressed to a higher score. Talonavicular arthritis was present in 51 preoperatively and 19 progressed. And the calcaneocuboid joint was only found in 7 patients preoperatively, but 12 progressed. So interestingly, though, and again, going back to Amanda's talk, arthritis did not necessarily correlate with results of pain or function in terms of their actual functional outcome scores. And so, you know, this is why, again, it's important that we're treating the patient and not just their x-rays. And then finally, in this study of 23 patients over a mean follow-up of 22 years, this is the longest one I could find, they found that ankle arthrodesis is associated with degeneration of other joints of the foot. These included the subtalar, talonavicular, calcaneocuboid, tarsometatarsal joints, and first MTP joints, which demonstrated significantly more degenerative changes than the non-operative side. And they also, similar to the previous study I mentioned, found reduced subtalar motion over time. But there was not an increase in knee arthritis incidence. And they also found a significant difference in activity limitation, pain, and disability compared to the fused and the contralateral legs. So overall, they concluded that while ankle arthrodesis provides good early pain relief, they may eventually develop arthritis, pain, and dysfunction. Interestingly, though, 67% were still happy despite these the progression of arthritis, and 88% would still have the surgery again. So in conclusion, here are some take-home points that after ankle arthrodesis, while it obviously reduces ankle motion itself, there is notable compensatory motion through the subtalar joint, midfoot, and medial column, as well as the ipsilateral hip and knee and contralateral knee and ankle. And with gait, arthrodesis results in improved speed and step length compared to their preoperative arthritic ankle, but with persistent asymmetry in gait, so it does not bring them back to a normal ankle gait pattern. And finally, despite these early improvements, patients can expect long-term adjacent joint arthritis in the subtalar, talonavicular, and calcaneocuboid joints, as well as in the midfoot, but not in the knee. And this increased motion in the subtalar joint early predisposes to a reduced subtalar motion over time. But even with that long-term, outcome, it's still a good option and still something to use in the correct patient. Thank you.
Thank you so much, Emily. There was one question by Nancy in the chat that asked about really the comment about AVN in the talus, and how does that in your algorithm of treatment plans for ankle fusions, does it impact outcomes? Does anybody want to tackle that?
I can't say I found anything specifically about that when I was making this. The question is, if you have preoperative AVN before your fusion, what are your outcomes?
Yeah, I think, I also think AVN can be partial, can be complete. And honestly, with bone grafting and bone filling opportunities, you know, we may be able to overcome those with ankle fusions. But I'm not sure that people have diced it up. Did you, as a variable? Anybody else see that in their readings and review?
I didn't see anything specifically on AVN other than I think, again, there's such a wide variety of different types of AVN or how much of the talus is affected. So I think it would be challenging to kind of find a study or do a study just based on that. But again, I think with bone grafting, I guess depending on how much of the talus is affected, you know, taking iliac crest bone graft or using some autograft may be helpful.
Yeah, well, Nancy, stay tuned. It's, you know, we're the research center at Rochester, so we'll see what we can do. So I'm going to turn back over to Dave, who can talk about his area of interest.
All right, hopefully you guys can all see this okay. We're going to talk a little more about some of the outside the box stuff with fusions. You guys have now heard very nicely about some of the patient-reported outcomes and the indications for ankle fusions, and a little bit more on the exact functional outcomes and some of the objective measures. We're going to bring it back to some of the patient-reported outcomes, and we're going to compare a couple of little subsets of ankle fusions and techniques, give you guys a little more detail for when you're picking how you do your surgery and talking to your patients. So also nothing to disclose for me. We're going to start a little bit with talking about sports and return to sports, because lots of these patients are younger, as we mentioned, and Emily went into this a little bit. A couple scales that you're going to see and are fairly common in some of the literature are the UCLA activity score, kind of runs from 1 to 10, where patients are either 1, not very active at all, really homebound, up to 10, which is impact sports and everything in between. Then the Tegner activity scale, which is also pretty prominently used in the research, and also ranges on 0 or 1, where patient is really, really limited to level 10. But this really breaks down the subsets of sports a little bit more, even within which competitive sports, based on the impact levels. So just kind of keep those in mind as we talk about a couple of studies. I can get this to move. There we go. So as we mentioned a little bit earlier, about 70–75% of patients return to some athletic activities. Depends on the study you read, but that seemed to be a pretty persistent number. And that can take up to 2 or 3 years for some patients. They've been pretty limited for a while. Sometimes it takes time to get back to this stuff. But for the most part, they do end up fairly similar to their pre-op sports participation. You don't have people that weren't athletes before suddenly becoming athletes after an ankle fusion. That UCLA score, people were hitting around a 7, so getting to some of the moderate impact sports. That's the stuff you'd expect or are probably recommended to your patients: the cycling, the swimming, the hiking, the skiing. You know, things where the skiing, at least your ankle's locked up in a boot, and some of the other things you can kind of control how intense those are. You are not getting as many people going back to football, soccer, rugby, things like that. And overall, if you compare it to total ankle literature, people are really getting back at about the same level. So one isn't necessarily that much better for return to sports, though some studies did show a little bit of a preference towards ankle fusion. Hard to know if that's because these patients trend towards a little bit younger. The Tegner score tended to actually decrease a little bit post-operatively. So it went from around a 4 to around a 3. It's not a drastic change that brings them in, keeps them in the moderate work, kind of mild labor to low impact sport levels. No one's up in that 7 or 10 level doing the competitive sports like we saw, like we had just mentioned. That said, in these same studies, patients' foot and ankle disability indexes improved. So they're definitely getting better, but athletics are definitely pushing the limits on the ankle. So yeah, you're probably gonna be more likely to be this guy after an ankle fusion compared to this guy. So just something to keep in mind for patients and kind of their expectations, especially in those post-traumatics that were young, healthy folks before their injury. What do we think? What are we usually recommending to our patients and when patients ask? So when we poll surgeons, foot and ankle surgeons, they were more restrictive on this, on ankle fusions, and compared to other foot fusions. Some of the studies kind of compared midfoot fusions, hindfoot fusions, MTPs, and then the ankle. Obviously a bit of a bigger joint, a little bit more limiting. Most of us seem to be okay with golf and skiing, a little bit of a mixed bag on whether people allow tennis or jogging, and most are pretty restrictive on that higher impact sports, football and soccer, and lots of running or distance running. It's just a lot of strain on the surrounding joints, probably has a chance of progressing that adjacent joint arthritis. What are the peak functions that some patients were able to get to? So we're going to go a little bit into the outliers. We all have these patients that do incredible, even though you do the same surgery on 100 different people. We already mentioned earlier some of those limits on kneeling, since you can't really flex your ankle to push off the ground or get comfortable or sprinting or distance running. But there are patients that are able to do 10-hour hikes. Patients are able to run 1,000 meters or 3/4 of a mile for you Americans. You're able to kneel for an hour compared to just that 10 minutes like we mentioned earlier. And even a small subset was able to do some short sprinting. So it's not completely lost for everybody, and everyone's a little bit different here. So it's good to know the outliers if you have those really athletic patients that might be willing to push a little bit harder, but these are definitely the outliers. So what happens if you have 2 bad ankles? A little bit of a different subset of patients. And as we saw in some of Emilie's studies, when patients have 1 ankle fusion, their other side and some of the other joints start to accommodate. So how do you do with 2? And good news, you still do okay. Obviously, this patient may have been a little limited beforehand and may not be trying to push the limits quite as much. But one study kind of showed with the JSSF scores that a unilateral fusion jumped from 40s to 90. Bilateral was pretty close with 39 to 87. So pretty good jump there. They had another a self-administered foot evaluation questionnaire, which I know isn't one of our common questionnaires, but it was nice to compare all these separate domains here of pain and physical function and social function and shoes. And it showed pretty similar scores again, a little lower in bilateral, but overall patients were still pretty happy with their function with these things. So how are you doing them? That's the next question, right? We know people do okay, but you scoping, are you open? Obviously a little bit of personal preference and how your facilities are set up and your experience. Some studies that compared some arthroscopic and open with a couple of years follow-up showed some of the things we expect with arthroscopy and smaller and less invasive surgeries. There's a little bit less VAS pain scores, 2 compared to 4 in the peri-op period. At 6 months, though, the SF36 physical function was still actually better for the scope group, almost 60 versus almost 50. And the AFAS, I know we mentioned not validated, at 2 years was still higher by about 10 points as well. A bigger kind of meta-analysis type study compared a couple hundred arthroscopic versus over 100 open. This had 5-year follow-up. This compared the ankle osteoarthritis and ankle arthritis scores, which those are validated, which is helpful, but showed more similar improvements really at all the intervals all the way up to 5 years. So maybe the scope versus open doesn't matter as much. Maybe there is some kind of early changes, especially with the less invasive procedure, but in the long run, if you do a good job and get the fusion, then people are going to be reasonably happy with these. So say you have a fusion, it looks great, it's healed, patient's still not happy. They're painful, or they become painful down the road, or maybe they start to get that painful peritalar arthritis in those adjacent joints. So a couple folks have started to convert these to total ankles. So we're doing some takedowns. This is getting a little easier with some of the patient-specific instrumentation. So one study took 51 patients, average age was about 62, so it's still pretty young. 4-year follow-up on these, and all of their markers that they measured improved. So the VR12 physical function scores, this is kind of functions like PROMIS, where 10 points is a whole standard deviation, went up about 10 points. On the physical function, the AOS pain improved pretty significantly. Their AOS disability score improved pretty significantly. VAS pain scores, which are important, dropped from 60s to around 30, and they did get some motion back. So even though they're ankle infused for a long time, they gained about 5 degrees or 3 to 5 degrees of dorsiflexion, plantar flexion. So other studies on this, another bigger study was more of a meta-analysis on a few different studies, took 170 patients. AOFAS score, again, we've heard the limits, but it did increase pretty significantly, which I think is still valuable. VAS pain really dropped down again, but they did have a couple people need to convert to a TTC. They did have a couple people need a BKA. So those are not insignificant complications, and definitely things you have to warn your patient about before undertaking something really big like this. And then just one more study on this topic, since total ankles are a little hot topic these days for sure. 28 patients, 30 ankles, almost 5 years of follow-up. AFAS hindfoot score definitely improved quite a bit, about 80% satisfaction rate, but still only 5 were really truly pain-free. 20 had moderate pain, and 3 were still fairly painful. And 1 patient required a conversion to a TTC. So if we reverse that, it's a little less common, in part, and you'll see why. I'll have some pictures for you. But if you have a total ankle that's failed and maybe you had an infection and you had to clear that, and they're not a great candidate for a revision to another total ankle, or they just don't want to deal with that again. What can you do? You can convert back to a fusion. You're going to need a bone graft. There's a big old hole in there. So one study had 17 ankles. They needed a big, large allograft in 16 of them. But their AFS scores were pretty good, at around 75, which is probably, this wasn't as detailed of a study, but still interesting. Just as an example, courtesy of Paul Fortin, where I did my fellowship. Thankfully, I haven't had to do this yet on my own. But really big void that you end up with these once you've taken out that total ankle, and you kind of make some space, kind of ream out the tibia to get yourself room for a femoral allograft. And then you plug in a giant chunk of bone, and usually need to convert to a TTC. You can see that how much the talus bone is lost in these. So that's kind of the downer of total ankles. When they fail, you really don't have a lot of great options left. Other folks have tried this with tantalum implants, some of the 3D printing options that are out there. They have not had awesome outcomes overall. 11 patients, 19-month follow-up, AFS scores were lower, SF36, which is a little bit of a better validated score, kind of on the lower side, 50s, 60s, and only half of them really healed. So a little bit tougher, but maybe it's still a salvage option for some patients. What do you do when you have an ankle that's got this type of deformity? Maybe a little aggressive for just an isolated ankle fusion, especially if this person has some subtalar arthritis like he did. So what are your other options? Maybe a TTC, just primary TTC for deformity and arthritis. So how did these do? It's a little more of an aggressive fusion. So there's some studies that compared this, which is nice, and group that took 28 ankle arthrodeses and 11 of the TTC arthrodesis with 5-year follow-up. Shockingly, pretty similar outcomes. SF12 score was 40s, so still on the low side. A little better in the ankle arthrodesis statistically, but it's hard to know if that's really truly that much clinically significant. Mental scores were similar. VAS scores were very similar, and similar amount of patients really met their desired activity level. The thing was that the ankle arthrodesis isolated patients blamed their inability to perform activities more on their ankle. The TTC patients seem to blame it more on other things. Maybe these are just patients with more troubles overall. And then another study that did 12 limb salvages with a TTC or a tibiocalcaneal, so maybe some of that big bone void. Definitely an increase in their oxygen consumption, so a little more work to get around, much like we see with some of the amputations. But they had decent outcomes, and it's still nice for a limb salvage. Better to have a leg than not, at least for most patients. And they still had physical function scores around kind of the mean and really low VAS pain scores in these studies. So in summary, from kind of a little my section here, ankle fusion is still really good for pain control. It's not perfect. VAS scores still seem to hover around the 2 to 3 range for most studies. So other people are still going to have some soreness. There's going to be some limits to the function. It is often going to be similar to pre-op. Amanda showed that with some of our data right here out of U of R, but that really corroborates with lots of other data out there, especially as far as you get to the return to sports or higher levels of function. Probably won't improve much for most patients. You can convert to arthroplasty. You can convert back. That can be successful and have reasonable patient outcomes, but it's still risky. And you kind of saw those studies to temper your expectations. Make sure that's a really lengthy discussion you have with patients before you jump to something big like that. You can scope them. You can do it open. You can really do whatever works for you, as long as you do a good job and get the deformity corrected and get the alignment right and get the bones to heal. And then some of those bigger surgeries, things like TTC fusions, those can still have pretty good function. Those are really small studies, but it's also not a super common procedure. So something to think about that it is still an acceptable thing to do for patients. Just to kind of bring things back, because we talked about this a little bit earlier, I want to leave you with this note, something to think about as you read studies and hopefully do studies. Validated outcome measures. So these are things that have gone through a little more strict criteria, and we know that these are more responsive and are going to give you better detailed answers that we can really trust in the literature. One is PROMIS. Gotta, give a shout out to that, since we use that plenty here at the university. But other common things that we see, VAS pain score is a validated outcome measure, the SF 36 and 12, the FAM, not a super long survey, but still validated. The ankle osteoarthritis score is, AOFAS is not, the AOFAS does not recommend using that as an outcomes score anymore. A lot of studies were recording that for quite some time, so it's a bit of a comparison, but it doesn't have the same responsiveness as some of these other things. So take it with a grain of salt when you see that out there. So from the University of Rochester and all of our crew here, thank you very much. And open it up for a few questions if you have any.
If you want to put any questions in the chat, we're happy to try and answer those. I think you did a really great job, all three of you, in highlighting the outcomes, circling around just basic outcomes, general health status outcomes, sports-related outcomes, gait-related outcomes, outcomes with different procedures related to ankle arthritis. So I thought it was fantastic. I don't see any questions coming up in the chat, so I'm going to now test the experts.
Well, Judy, can I ask a quick question?
Oh, Selene, you certainly can.
All right. Great job, guys. I really appreciate looking at the data the way you are. But Dave, quick question for you. You're looking at TTCs and you looked at the femoral head allografts, and I was actually surprised to see that your outcomes were better with that than the cages, because I can tell you anecdotally, in my practice, it's the actual other way around. And so I wonder, is it possible that those TTC patients have not been followed long enough to start seeing the graft collapse that occurs later on, and the non-union that becomes more painful as that graft collapses? You know, how would you explain that data? Because it's, you know, I don't know if you heard the guys talk about the cages earlier today and even late last night. It's kind of the opposite of what the data you said suggests.
Yeah, I think part of it is these are smaller studies. I think people need to probably put out some better studies, and our 3D printing is a lot better now. So I think that some of those early cages may have had worse integration. Maybe they were not the best patient selection. I've heard a lot of good things. I haven't done much with the cages personally yet, but I do think that the grafts are tough, and they don't all take very well, and they can collapse later on. So I think some of it just takes time, and I do think that the tech is really, really changing, especially with our 3D printing. Some of the porosity and everything, even the backing on the total ankle implants, just the change they made a couple of years ago, and a few of those, you can see how much better that bonds. So I think hopefully those of you with good outcomes will publish them, so people have a good reason to start to try them, because we know they're not cheap too. And they hopefully, if they're worthwhile, and we see the data out there, it is worth it, and it's kind of more convincing for hospital systems to support that too, if you want to try something custom as a limb salvage, because we don't all get that either. That's the thing to think about, is we get a femoral head allograft sitting in a freezer. Our hospitals don't always support us doing something custom unless we have a good reason to back it. So important stuff there too, because if we're the ones publishing that, we kind of get to drive the boat on what insurance sees and what hospitals see too. So appreciate the experience on that.
No, appreciate it. Thanks.
I think everyone recognizes that you know, new innovation takes almost 7 years to populate into our usage, and clearly then after that you have to have time for papers and follow-up, so it does lag behind. And the numbers I put in the chart, you know, whenever anybody's in the chat, anyone's publishing and putting out percentages, it's always a way of trying to get around the small numbers that you might have in your studies. So, you know, just be critical of the literature. There's a question about TTC fusions and how many objective varus positions. I'm not sure exactly I understand what, I would say thou shalt not varus, but who wants to tackle that?
Yes, I agree. You do not want them in varus. You still need to get them into that valgus position to kind of open up the midfoot, as Emilie kind of give you guys that nice little biomechanics there, showing how the position of the hind foot really can unlock the midfoot. As you lock up the subtalar joint, you're taking away even more motion. So probably even more important to get it over there in valgus as far as you can. But it's sometimes hard.
It can also lead to lateral overload and issues on the lateral aspect of the foot. So important to get it not in varus.
I think there's I saw a paper relatively recently about putting the nails in and how they kind of kick you into doing some varus positioning sometimes. So it is technique-wise, it can be challenging. So I think people should really keep an eye on that. Osteotomies can get you out of trouble for varus. There's a question about the AOFAS not being validated. Honestly, I'd refer you right to the position statement that's published in the Foot and Ankle International that was written by Tim Daniels, stating that we should not be using the AOFAS clinical rating scales because of the subjective nature of the questions. It actually is a physician answered scale, not a patient reported scale. So anybody can email me. My email is easy to find, and I'm happy to go elaborate about that. Another question about nail fusions causing a lack of valgus in the hindfoot. We just tried to state that, I think. So hopefully that they probably saw that same paper.
Yeah, I think
you can put that paper in the chat. That would be great.
I think with the nails, a lot of people are using straight nails, which I think are fine, especially when you have a lot of deformity. Because once you get it straight, you go straight, rather than some of the old trauma nails. But the trauma nails had some valgus. So if you are kind of kicking along the inside border of the calcaneus, especially if they're in varus, you have a chance that as your nail goes in, it can pull it into more varus. So you just have to be really careful. You sometimes have to medialize the talus and the calcaneus a little bit to get a start point in your calc. That's kind of my little technical tip. Sometimes when you've got the anterior exposure, you can carve out a little bit of your medial nail, so you can shove the foot more medial underneath. So you really can get the calc and the talus, which are kind of more lateral structures, centered underneath the tibial canal. So when the nail goes up, it doesn't force your foot over into varus to get it underneath the tibia. So that's kind of my little technical thing to think about with those, especially with the straight nails. If you're using a curved nail, it's less of a big deal.
I'm sure that there were other, I know there were other presentations that talked about technique, but I just want to get the buy-in from this group. So currently, are you using anterior plates for your ankle fusions?
I am.
Yeah, I am. I'm using anterior plates and then medial and lateral screw as well, a large frag screw.
Haven't done any in practice yet, but that's the plan.
I think anybody using a home run screw any longer? Yeah.
I have in revisions just to add something different with a different path.
Yeah, I think it makes sense in revisions, but in my primaries, I'm not doing a home run screw anymore.
They're asking about the technique that you use. What approach are you using? So if we're using the anterior approach primarily, anybody using posterior lateral approaches?
I have. I've done it in a post-traumatic setting where they had posterior hardware already. They'd already had a posterior lateral approach from like a fracture. I've gone in and done that. I've done both fusions and TT fusions that way. Actually, a really nice look at the subtalar joint, but anterior if I can.
Agreed. That's the only time I've done it is for post-traumatic, that patients have already had an incision there in the back, and I've had to go posterior lateral to take out hardware.
How about bone grafting? Who's bone grafting their fusions? Anybody bone grafting their fusions?
I just did one. It was kind of an interesting case. She had a large amount of AVN in her distal tibia after an accident. And so I ended up taking Crest just to fill the defect. So I took Crest allograft. I don't routinely use allograft on my fusions, but in that setting with AVN, or if there's a big defect, I will take some allograft as well.
I was completely influenced by one of the multi-centered studies that we were involved in about bone grafting. And my feeling is that if the bone doesn't touch, it doesn't heal. They can't jump gaps. So often, even if I use just a little tiny bit of bone graft, I'll put a little tiny layer of bone graft in so that it can fill kind of the nooks and crannies that my curette has caused. We all like compression across, but we all know that we don't get compression evenly, even though we try to. So bone graft helps me fill those deficiencies.
Are you guys, anybody using biologics besides bone graft, meaning PDGF or BMP, especially for your patients with comorbidities or your TTCs?
Yeah, I only use I've only used no autograft any longer. I just use bone bank bone because and I have used a type of mesenchymal stem cell graft that came from Florida, and that's what I had been using for a long time. So it wasn't that expensive. It was equivalent essentially to some of the other costs, and that had to be aligned as well. What about the rest of the crowd?
I use one of the commercial allografts, kind of like you're saying. Just it's the one that the university has. I didn't really pick it, but it kind of has a little bit of growth factor and stuff in there. But I haven't added BMP or anything like that. I might consider it in someone who's failed, especially with the comorbidities, like you mentioned.
I did add it on a patient who had 2 previous non-unions, and I was the 3rd attempt, and so I did use it in that setting, and it healed. So, yay!
Kitchen sink. Yeah. Okay. What about post-operatively? When do you let them walk?
I'm a 6-week person for the most part.
Yeah, I'm 6 weeks.
Again, haven't done it, but I'm a 10-week.
Well, 6 weeks in a cast, are they going to be immobilized still?
I put them in a boot. At 6, I let them start walking in a boot so they can at least take it off to sleep and stuff.
It depends on the patient. It depends for me. I trained with Judy Baumhauer, and so I do love foot jail, and I do love casting people. I think if I feel like they're an older person and going to be a cheater, I put them in foot jail. If I think that they could, maybe stay off of it and they're pretty reliable, I'll sometimes put them in a boot, but I'm pretty quick to cast them for a period of time. But I'm still 6-weeker.
I trained with John Campbell, who's a good friend of Judy Baumhauer, and I have never heard the phrase foot jail before, but I like it.
Yeah. All right, there's a question that says, if you have an angular deformity, do you have a limit for what you'll do? Mini open versus anterior approach? I'll tell you, my anterior approach is limited by getting the plate in there. So I don't know that it's not the big, the old plates where they, really went right up the leg and you had to make a huge incision. Now with the smaller plates, where you're only having 2 screws above and 2 screws below, you can make those incisions a little bit smaller. What about the rest of the crowd?
I think it's a continuum. I start with a small anterior, just like you mentioned, Judy, to try and go in the small plates in. And if I can get correction, great. If there's something in the gutter, if it's a varus ankle and I need to debride that lateral gutter to get the talus over, you make it a little bigger. You do what you need to get it. But I think you can go from a little incision to bigger if you need to, and that can get bigger and bigger if you need to. But that's kind of the nice thing about the anterior approach is it's a extensile and it's safe.
Okay. Cool. And
Judy,
we're going to wrap it up. Yeah, we're going to wrap it up. Thank you so much for that. And this is my first time meeting all 3 of you guys. So hopefully get to know you better through the meetings and through more of these. So appreciate everybody's insight and expertise.
Thanks, Selene, for doing this. Thanks for all the work.
Absolutely. Thanks, guys.